an active consultant at the section of dermatology under the Department of Medicine. With me this morning is Dr. Joko Damasco, one of our dermatology residents. Good morning, Joko.
Morning po, ma'am. Good morning, everyone.
Good morning. Dr. Joko will be assisting me in case I'll be having any technical difficulties. He'll be calling my attention and he'll be warning me if I have a few more minutes to go. Okay, so our topic for this morning will be cutaneous drug eruptions and also benign and malignant tumors of the skin. So this is quite a long topic, so I hope that all be able to pay attention until the very end. Okay, so let's begin. First, with the learning objective. So at the end of this lecture, you should be able to recognize cutaneous drug reactions and be able to identify the possible offending agents using a drug timeline, and then recognize the presence of tumors on the skin based on morphology and other clinical features, and be able to differentiate among the different cutaneous drug reactions and different skin tumors based on history and physical examination findings, and then come up with a primary impression together with a differential diagnosis for a given dermatologic case. And then identify applicable diagnostic tests that may aid in the confirmation of a diagnosis, and then become familiarized with some staging and prognostic criteria that may be utilized, and enumerate treatment options and give management plan for the cutaneous drug reactions and benign and malignant tumors as well. Okay, so Dr. Joko, can you see my slides and can you hear me properly?
Yes, ma'am. We can see your slides and your audio is clear.
Okay, thank you, Dr. Joko. Okay, so this will be the outline that we will be using for cutaneous adverse drug reactions and for benign and malignant tumors of the skin. Okay, so let's start with cutaneous adverse drug reactions. So this can range from common nuisance eruptions to rare life-threatening drug-induced diseases. Clinical manifestations include exanthematous, urticarial, pustular, and bullous eruptions. They may be limited solely to the skin or may be part of a severe systemic reaction, such as those in drug hypersensitivity reaction or SJS or toxic epidermal necrolysis. Fever is generally associated with such systemic cutaneous adverse reactions. So complications of drug therapy are a major cause of patient morbidity, and this account for a significant number of patient deaths. So that means cutaneous adverse drug reactions are serious reactions. Reaction pattern recognition can help narrow possible causes because different drugs are more commonly associated with different types of reactions. So there are populations that may have an increased risk of drug reactions. For example, patients with HIV or connective tissue disorders like lupus, non-Hodgkin's lymphoma, and hepatitis. So, in approaching the patient, we should sharpen our clinical eye in identification of patients whom we suspect adverse drug reactions. So, if we do suspect, we should obtain a detailed medical history with specific details on the time of onset of skin lesions in relation to the medication history. On PE, we should take note of the morphology of the skin lesions and the systemic features that are present. So for etiology, the list of implicated medications in adverse drug eruptions is very exhaustive. This includes all prescription and non-prescription substances, as well as naturopathic remedies or herbal medications, radiocontrast dyes, even eye drops, and illicit drugs. So we should be very detailed in our medication history if we're suspecting adverse drug reactions. Identification of potential or causative or culprit medications to help us, the guide is that more likely these are the new drugs started within the preceding 3 months, especially those within the past 6 weeks. So drugs that have been used intermittently, we should also inquire about these. So for the pathogenesis, most occur as a result of immune-mediated reaction to medication and can involve IgE or IgE or lymphocytes. The multiple possible reactions result in heterogeneous spectrum of presentations. The immune system may target the native drug, its metabolic products, its altered self, or a combination of these factors. So for cutaneous adverse drug reactions, they are usually either type 1 immediate hypersensitivity reactions or type 4 delayed type hypersensitivity reactions. Okay, so let's begin. First on our list would be the exanthematous drug eruption. So this is sometimes referred to as morbilliform or maculopapular drug eruption. It's actually the most common form of drug eruptions. And among the drug eruptions, it accounts for approximately 95%. So the onset, it could already occur within 1 week of initiation of therapy, and may appear 1 to 2 days after the drug therapy has been discontinued. But still, even if it's written here 1 week of initiation of therapy, the medicine could have been taken as far as 2 months ago. Okay, so for differential diagnosis, for patients presenting with exanthematous drug reaction, we should still try to rule out other etiologies, like it may be an infectious exanthem, mostly viral in origin, a collagen vascular disease, and other infections. So we still have to rule these out because they also present with an eczematous eruption. So for the clinical presentation, this presents with erythematous, coalescing macules and papules. So it's a maculopapular rash. So there's absence of blistering, pustulation, or other associated systemic signs. It typically starts on the trunk, then spreads peripherally in a symmetric fashion. Pruritus is almost always present, and resolution occurs within 7 to 14 days if the drug has been promptly discontinued. It occurs with a change in color from bright red to a brownish red, which may be followed by desquamation or scaling of the skin in the later stages. So for etiology, it can be caused by a variety of drugs. Most commonly for exanthematous drug eruption are the beta-lactams or the penicillins, sulfonamide antimicrobials, non-nucleoside reverse transcriptase inhibitors like nevirapine, anti-epileptic medications also. So for the pathophysiology of this, drug-specific T cells play a major role in exanthematous, bullous, and pustular drug reactions. And then there's also a drug-virus interaction that we could take note of, because in patients infected with HIV, the risk of developing an eczematous eruption while being treated with sulfonamide antibiotics increases dramatically compared to patients who don't have HIV. Okay, so next on our list would be drug reaction with eosinophilia and systemic symptoms. So let's just call this DRESS. So for DRESS, it's also an eczematous eruption but this time in conjunction with fever and internal organ involvement. This is a more serious reaction versus exanthematous drug eruption. It is also known by other names such as hypersensitivity syndrome reaction, drug-induced hypersensitivity reaction, and others. So etiology, it occurs in approximately 1 in 3,000 exposures to the following medications: to aromatic anticonvulsants, lamotrigine, sulfonamide antimicrobials, dapsone, nitrofurantoin, nevirapine, minocycline, metronidazole, and allopurinol. So these are the most common drugs causing DRESS. So the onset, on the average, initial symptoms starts 1 to 6 weeks after exposure. So how does it present? It occurs most frequently on the first exposure to the drug, and then fever and malaise are often the presenting symptoms. And then there would be atypical lymphocytes with subsequent eosinophilia that may occur during the initial phases of the reaction. And then, although most patients have an eczematous eruption, meaning exanthematous, meaning maculopapular or multiple erythematous coalescing macules and papules, so even if it usually presents with an exanthematous eruption, the skin lesions can progress to a more cutaneous manifestation. For example, it can look purpuric. Okay, so for the systemic symptoms that's associated with DRESS, there's almost always fever, internal organ inflammation of the liver, kidney, CNS. Internal and organ involvement can actually be symptomatic or asymptomatic. That's why we should work the patient up. And then sometimes there's also an immune-mediated thyroid dysfunction. This is one of the long-term possible complications in DRESS. The patient may have hyperthyroidism or hypothyroidism eventually. Okay, and sometimes this is delayed. It may not present until 3 to 12 months after the first symptoms of DRESS has appeared. Okay, so next condition would be urticarial drug reaction. So first, what's urticaria? How does it present? It's characterized by pruritic red wheals of various sizes. Individual lesions generally last for less than 24 hours, although new lesions can commonly also develop. So next is angioedema. This is a reaction when deep dermal and subcutaneous tissues are also swollen. Frequently, this is unilateral and non-pruritic. This lasts for 1 to 2 hours, although it may persist for 2 to 5 days. Okay, so urticarial drug reaction can present with urticaria and or angioedema. So for the pathophysiology, it's usually type 1 immediate hypersensitivity reaction. So when associated with drug use, urticaria and angioedema are usually indicative of an immunoglobulin E mediated immediate hypersensitivity reaction. This mechanism is typified by immediate reactions to penicillin and other antibiotics. Signs and symptoms of IgE-mediated allergic reactions typically include pruritus, urticaria, cutaneous flushing, angioedema, nausea, vomiting, diarrhea, abdominal pain, nasal congestion, rhinorrhea, laryngeal edema, and bronchospasm or hypotension. But urticaria and angioedema can also be caused by non-IgE-mediated reactions. That means it can also be type 4, a delayed type hypersensitivity reaction that result in direct and non-specific liberation of histamine and other mediators of inflammation. So drug-induced non-IgE-mediated urticaria and angioedema are usually related to non-steroidal anti-inflammatory drugs or NSAIDs and angiotensin-converting enzyme or ACE inhibitors. Okay, so next, the fourth condition is acute generalized exanthematous pustulosis or AGEP. So AGEP is an acute febrile pustular eruption. Incidence is approximately 1 to 5 cases per million per year. For the onset, this usually occurs 24 to 48 hours after initiation of the implicated drug. But again, as I mentioned earlier, even if I wrote the average onset of these different drug reactions, you should still get the medication history as far as 2 months ago. Okay, or even 3 months. So for the etiology, this is most commonly associated with beta-lactam, macrolide and quinolone antibiotics, anticonvulsants, sulfonamides, calcium channel blockers like diltiazem, and terbinafine. And also, even if I would enumerate the most common drugs associated with this specific condition, all drugs are still possible. But still, take note of these most important drugs for each condition and average onset for each condition for your exam. Okay, so for clinical presentation of AGEP, this is characterized by small, monomorphous, non-follicular, sterile pustules concentrated on the trunk and intertriginous regions. And then generalized desquamation occurs after approximately 2 weeks. So your clue here for AGEP is it's kind of toxic looking because the patient is erythematous, then has a lot of pustules. And then eventually, when these pustules dry up, the patient's skin would desquamate. Okay, so systemic features, so patients also quite toxic because there's leukocytosis with neutrophilia, fever, elevated liver enzymes with steatosis or hepatomegaly, renal insufficiency, and pleural effusions with hypoxemia. So differential diagnosis to consider in AGEP are pustular psoriasis, subcorneal pustular dermatosis like Sneddon-Wilkinson disease, and in severe cases of AGEP, toxic epidermal necrolysis should also be considered. Okay, so for the management, just like all the drug eruptions, discontinuance of therapy is necessary. And some patients may require the use of corticosteroids. So it depends on the case. Not all patients should be given corticosteroids. Okay, next condition would be a fixed drug eruption. So fixed drug eruption usually presents as solitary dusky macules that recur at the same site. So the onset, it develops from 30 minutes to 8 to 16 hours after the ingestion of the medication. So for the clinical presentation, it usually appears as a solitary round or ovoid, erythematous, bright red, or dusky red macules that may evolve into an edematous plaque. So bullous-type lesions may also be present. So aside from the erythematous plaque, there could be a bullae. So common areas involved are the genitalia, perianal area, hands and feet, although they can occur anywhere on the skin surface. And symptoms include burning and stinging sensation. So after the initial acute phase, lasting days to weeks, residual grayish or slate-colored hyperpigmentation develops. On re-challenge, not only do the lesions recur in the same location, but also new or additional lesions often appear. So for fixed drug eruption, what happens is every time that the patient takes this medication, his lesions would flare up on the same area. So when the example, he already stopped the medications, the area will, the erythema on the area will resolve and turn into slate gray. But eventually, when he takes the medication again, that area will again become erythematous or flared up. And aside from that, additional fixed drug eruption lesions could occur. Yan. So for systemic symptoms, there could be fever, malaise, and abdominal symptoms. For differential diagnosis, widespread or generalized fixed drug eruptions may mimic toxic epidermal necrolysis, which we will discuss later, but differs in its absence of systemic involvement and more marked hyperpigmentation. So yun, in fixed drug eruption, there's usually no systemic involvement. If ever, maybe fever, ganyan lang, but no multi-organ involvement. And then it's usually more hyperpigmented since repeated injury makes it hyperpigmented eventually, those lesions. Okay, so for the etiology, more than 100 drugs have been implicated. So these are the most common ones: NSAIDs, acetaminophen, and antibiotics as the most frequent culprits. Then also pseudoephedrine, trimethoprim sulfamethoxazole, and less frequently, it has also been reported that there are also food-initiated fixed eruptions that exist. It's also important to consider when assessing the causation in a specific patient. Okay, so for now, we have discussed exanthematous drug eruption, drug reaction with eosinophilia and systemic symptoms, urticarial drug reaction, acute generalized exanthematous pustulosis, and fixed drug eruption. So for before we proceed to the epidermal necrolysis, let us first discuss their diagnosis, clinical course and prognosis, management, and prevention. So for diagnosis, the diagnosis of cutaneous drug eruption involves the precise characterization of reaction type. So if you're suspecting a drug eruption, first you have to characterize it. Which ones on your list does it belong to? How does it present? So even the most minor cutaneous eruption should trigger a clinical review of systems because the severity of systemic involvement does not necessarily mirror that of the skin manifestations. So for example, the patient presented with an eczematous maculopapular rash and you're considering drug, automatic get a detailed review of systems and try to do laboratory exams because it might not just be exanthematous drug eruption. What if it is DRESS, the one with systemic symptoms? So hepatic, renal, joint, respiratory, hematologic, and neurologic changes should be sought, and any systemic symptoms or signs should be investigated with laboratory examinations. So fever, malaise, pharyngitis, and other systemic symptoms or signs should also be investigated upon. So the usual screen, so routinely we would, for drug eruption patients, all drug eruption patients, routinely we would do full blood count or CBC, liver and renal function tests, and a urine analysis at the very least. But depending on your review of systems and PE, more lab tests may be required. Okay, so skin biopsy should be considered for all patients with potentially severe reactions. Actually, in practice, all patients with drug reactions, we do skin biopsy to document if it's really a cutaneous adverse drug reaction or something else. Okay, but very much required skin biopsy for severe reactions. Those with systemic symptoms, erythroderma, blistering skin presentation, skin tenderness, purpura, or pustulation. as well as in cases, of course, in which a diagnosis is uncertain. So some cutaneous reactions, such as fixed drug eruption, are almost always due to drug therapy. So if you see lesions classic for fixed drug eruption, more or less it's due to drug or because for other eruptions, including exanthematous drug eruption or urticarial eruptions, of course, they may have non-drug causes, in which we should consider the differentials. Okay, so there's no gold standard investigation for confirmation of a drug cause. Instead, diagnosis and assessment of cause involves analysis of a constellation of features such as, so we have to do a drug timeline in order to know what caused the drug eruption. So we have to know the timing of drug exposure of each drug and then the reaction onset and then the course of reaction with drug withdrawal or continuation. And then a history of similar response to a cross-reacting medication in the past, and previous reports of similar reactions to the same medication again in the past. So for the clinical course and prognosis, the course and outcome of drug-induced diseases are influenced by both the host and disease factors. So the vast majority of simple drug exanthems are self-limited. That's for the exanthematous drug eruption. In complicated exanthems like that for DRESS, there can be significant morbidity and mortality related to systemic manifestations. So SJS10, which we'll be discussing next later, is associated with the highest mortality among the cutaneous adverse drug reactions. Okay, so patients will have a recurrence if exposed to the same medications. Okay, and usually if the patient has been exposed again to the same medication, the onset is faster, the reaction, and usually more severe. So if that's why we really have to know or investigate what caused the drug reaction so that the patient will not be exposed to the same drug again, nor to similar drugs. Yan. So in more systemic eruptions, the recurrence could be even severe and fatal. Yeah, because like I mentioned, if it's already a recurrent, it's usually more severe and could be severe and fatal. So the recurrence rate in SJS10 may be as high as 20%, as reported in a series of pediatric cases. So that's for SJS10. Okay. So for management, patients who have developed a severe cutaneous adverse drug reaction should not be re-challenged with a drug. Desensitization therapy with a medication may also be a risk, so it's also not recommended. And cutaneous drug eruptions do not usually vary in severity with the dose. So people you might say that you're gonna give a small dose just to test if the patient will react. We shouldn't do that because cutaneous drug eruptions do not vary in severity with the dose. So even a small amount can cause, if there's a recurrence, can cause a severe reaction. So antihistamines, topical steroids, or both can be used to alleviate symptoms of drug reactions. So resolution of the reaction over a reasonable time frame after the drug is discontinued is expected of those with a drug etiology. That's why it's very important to discontinue promptly the suspected drug or drugs. So a reaction suggestive of a potentially life-threatening situation should prompt immediate discontinuation of the drug, along with discontinuation of any interacting drugs that may slow the elimination of this suspected causative agent. So although the role of corticosteroids in the treatment of serious cutaneous reactions is controversial, most clinicians actually choose to start prednisone for cutaneous adverse drug reactions at a dosage of 1 to 2 milligrams per kilograms per day when symptoms are severe. Yan. So since if the patient has concomitant infections, of course you have to manage the concomitant infection if you plan to give prednisone. Okay, so for prevention, cutaneous reactions to drugs are largely idiosyncratic and unexpected. So once a reaction has already occurred, however, it is important to prevent future similar reactions in the patient with the same drug or any cross-reacting medication. So for patients with severe reactions, it's advisable, for them to wear a bracelet detailing the nature of the reaction. Like, for example, indicated penicillin allergy patient. So it is also important to note that some of these cutaneous drug hypersensitivity reactions can be inherited. Hence, you should inform your the patient should inform his or her relatives because first-degree relatives, most especially, should take caution in taking the suspected drug as well. Okay, so next we proceed to the most serious cutaneous adverse drug reactions, which is under epidermal necrolysis. Okay, so Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, or TEN, are acute life-threatening mucocutaneous reactions characterized by extensive necrosis and detachment of the epidermis and mucosal epithelium. Hence, the designation epidermal necrolysis. Okay, so there's necrosis in the epidermis. These two conditions, SJS and TEN, share the same clinical pattern and histologic findings, even etiology, risk factors, and mechanisms. They are considered as severity variants of one disease entity that differs only in the extent of skin detachment related to the person's body surface area. So epidermal necrolysis is actually rare compared to the less severe drug reactions. It can occur at any age, but the risk increases with age. Patients infected with HIV, again, are an increased risk for epidermal necrolysis. Also, to a lesser degree, patients with collagen vascular disease and cancer also have an increased risk. Overall mortality rate for epidermal necrolysis is 10% for SJS and about 50% for TEN. So increasing age, significant comorbidity, and a greater extent of skin detachment, of course, correlate with a poor prognosis. Later, I'll introduce to you the prognostic scoring system for epidermal necrolysis, which is the score 10. Okay. So drugs are the most important etiologic factors, of course. There's also a small role of infectious agents, but it's much less prominent. So if on drug history, example, the patient, already has epidermal necrolysis, and then on drug history, there's really nothing, like totally nothing, not even eye drops, not even anything, wala talaga, herbals, none, then we should also consider infectious agents. Okay, so for drug etiology, the risk seems confined to the first 8 weeks of treatment. So we will go for drug history for the past 8 weeks. What all the drugs that the patient has used in the past 8 weeks or 2 months, we should list them down. Okay, and one by one, we should check if the patient has already taken this before, if with reactions, or if it's the first time, etc. Okay, so most commonly, the reaction onset is during the first continuous exposure between the 4th to the 28th day. So most commonly, but we can go as far as 8 weeks before. Okay, so these are the high-risk drugs. So these are all the drugs on the right, but these are the most high-risk drugs for epidermal necrolysis. Antibacterial sulfonamides, aromatic anti-epileptic drugs, allopurinol, oxycam non-steroidal anti-inflammatory drugs, lamotrigine, and nevirapine. So a significant but much lower risk has also been reported for various groups of antibiotics such as cephalosporins, quinolones, tetracyclines, and aminopenicillins. So for the pathogenesis, patients with epidermal necrolysis have an altered regulation of the immune response to medications. So the immunologic pattern of early lesions suggests a cell-mediated cytotoxic reaction against keratinocytes, leading to massive apoptosis of the keratinocytes. So genetic susceptibility plays an important role in the development of epidermal necrolysis to a few high-risk medications. So for epidermal necrolysis, this involves type 4 delayed type hypersensitivity reaction. So on the patient's history, non-specific prodromal symptoms precede the mucocutaneous lesions for about 1 to 3 days before. This includes sore throat, runny nose, cough, headache, fever, malaise, followed by the cutaneous involvement already, meaning the appearance of erythematous macules and atypical targets of the skin that may become confluent, no, and on which blisters occur. So it's really, really bad, no? So erythematous macules and atypical targets that would coalesce or be confluent on which blisters would occur. So it's followed by symptoms heralding mucous membrane involvement. So there's going to be start of burning or stinging of the eyes, pain when swallowing or urinating progressively. There will be at least two mucosal involvements. So some cases may start with specific lesions on the skin and mucosa instead of prodromal symptoms. Some prodromal symptoms first. Okay, so whatever the initial symptoms are, their rapid progression, the addition of new signs, severe pain, and constitutional symptoms should already alert the clinician of the onset of a impending severe disease. So again, just to guide you in getting the patient's medication history on what to suspect, usually they are medications that have not been used previously, or if they have been used previously, they already also caused a reaction, and the exposure of which is the first continuous use, and it was started around 4 weeks or as far as 8 weeks to 4 days before the reaction onset. So here are the cutaneous lesions. The eruption is initially symmetrically distributed on the face, upper trunk, proximal part of the limbs, and then the distal portions of the arms as well as the legs are at first relatively spared, but eventually the eruption will rapidly extend to the rest of the body within a few days and even within a few hours. So this is a very serious drug reaction. So the initial skin lesions are characterized by erythematous, dusky red, irregularly shaped, purpuric macules which progressively coalesce or join together as one big lesion. So atypical target lesions with dark centers are also often observed. Here in the picture, we can see the atypical target lesions with a more violaceous deep red center. Those are where the blisters are gonna begin. Okay, so the confluence of necrotic lesions lead to extensive and diffuse erythema. And then the Nikolsky sign, I'm sure you already know the Nikolsky sign, or dislodgement of the epidermis by lateral pressure is positive on these erythematous zones. That means these erythematous zones will already uh, lead to dislodgement of the epidermis anytime. Just by a little trigger with doing the Nikolsky maneuver, they could already be dislodged. So at the next stage, the lesions will eventually evolve to flaccid blisters, which spread by pressure and break easily. It's also positive Asbo-Hansen sign. Okay, so the necrotic epidermis is easily detached at pressure points or by frictional trauma, revealing large areas of exposed, red, and sometimes oozing dermatitis. So in other areas, like a few areas, the epidermis may still remain for those that are not erythematous. So patients are classified into one of the three groups according to the total area in which the epidermis is detached or detachable. So even if it has not yet detached or blistered, as long as you know that that part is already deeply erythematous, that's already detachable. And we should consider that already in counting the body surface area involvement. Those areas which you know already will present with positive Nikolsky sign. Okay, so first, it's termed as SJS if there's less than 10% of the body surface area involved. It's called SJS10 overlap. If it's between 10 and 30% BSA and then involvement. And then TN if there's more than 30% of body surface area involvement. So the correct evaluation of the extent of detachment is sometimes difficult, especially in zones with spotty lesions, but we should just try our best. It is helpful to remember that the surface of one hand, meaning the palm, and together with the fingers, represent a little less than 1% of the body surface area. So that's how we count the percentage. So next, for mucous membrane involvement, in epidermal necrolysis, it's nearly always on at least two sides of mucosal membrane. So mucosal membrane involvement is almost always observed in these patients, approximately 90% of cases, and can precede or follow the skin eruption. So either skin eruption first or mucosal involvement first. It begins with erythema on the mucosal surface, followed by painful erosions. It could be the oral, or ocular, or genital, or nasal area that are involved, sometimes even the tracheal and bronchial mucosa. So this would lead to impaired alimentation, photophobia, conjunctivitis, and painful micturition. So let's see, for the oral cavity and vermilion border of the lips, so this is almost always affected. It's always most of the time, it's one of the mucous membrane involvement. It features painful hemorrhagic erosions coated by grayish-white pseudomembranes and hemorrhagic crusts on the lips. Okay, so just like in the picture. And then for genital erosions, these are also frequent, often overlooked in women. So we have to inquire about this or check. Okay, and it may lead to synechiae if untreated. Next, for conjunctival lesions, in approximately 80% of patients, the conjunctiva is always involved also. So it's manifested by pain, photophobia, lacrimation, redness, and eye discharge. So severe forms may lead to epithelial defect and corneal ulceration, anterior uveitis, and purulent conjunctivitis. Synechia between eyelids and conjunctiva can occur, and also shedding of the lashes. So for these patients with mucous membrane involvement, we should always refer them accordingly, like to ENT, to OB/GYN, to ophthalmology, and the like. Okay, so for complications of epidermal necrolysis, so during the acute phase, this is the most common complication would be sepsis. Okay, so for epidermal necrolysis, acute phase, most common complication is sepsis. Because the epithelial loss predisposes, of course, these patients to infections, which actually causes the main cause of mortality. Central intravenous lines are a source of infection also and should be avoided in these patients. So we'll just use peripheral lines if possible. And then Staphylococcus and Pseudomonas species are the most frequent pathogens that would infect these patients. About one third of positive blood cultures contain Enterobacteriae also. Uh, Not present on the skin, it's a finding that suggests bacterial translocation from gut lesions. Okay, so yun, a lot of different bacteria can infect these epidermal necrolysis patients. So we have to watch out for infections and eventual sepsis. So multi-system organ failure and pulmonary complications are observed in more than 30 and 15% of cases respectively. This is actually a high percentage. Okay, so for systemic involvement, usually there's really high fever, pain, weakness. Visceral involvement is also possible, particularly with pulmonary and digestive complications. So let's look into the pulmonary complications. Early complications occur in approximately 25% of patients. It's essentially manifested by elevated respiratory rate and cough, which should prompt strict surveillance. In most cases, chest radiographs are normal on admission, but can rapidly reveal interstitial lesions that can progress to acute respiratory distress syndrome, which is already associated with poor prognosis. So usually, we don't just do the chest radiograph once. So we have to assess the patient every day on what tests the patient would need to do or need to repeat. Okay, so next, let's go to gastrointestinal tract involvement. This is less commonly observed than pulmonary. With epithelial necrosis of the esophagus, small bowel, or colon, it manifests with profuse diarrhea, with malabsorption, melena, and even colonic perforation. Okay, so we should watch out for this also. And then renal involvement has also been reported. This presents with proteinuria, microalbuminuria, hematuria, azotemia, and these are not rare. So proximal tubule damage can result from necrosis of tubule cells by the same process that also destroys the epidermal cells. So the way that the epidermal cells are having necrosis, other organs can also present that way. So, but glomerulonephritis in particular is rare. Okay. So for differential diagnosis, the rapid progression of skin lesions and the severity of mucous membrane involvement should lead to considering potential EN. So that means if the patient has this rapid progression of skin lesions with mucous membrane involvement, our number one assessment should already be, primary impression should already be epidermal necrolysis. And then before we can, then we should also think of the other differentials that we may need to consider or need to test for. So usually we would really need to do histopathology for these patients. No, so we do skin biopsy for routine histologic studies. These are strongly recommended, especially if there are alternative diagnoses to consider. Like here, and there's a lot of things to consider for patients with blistering disorders. Okay, so on histopathology, we would note full thickness necrosis of the epidermis. Yan. So that's why it's called epidermal necrolysis. Okay, so laboratory examinations are essential for evaluation of severity, prognosis, and daily management for these patients. Okay, especially for the life-threatening conditions in intensive care units. So we would do almost daily laboratory examination as part of their close monitoring. So here's the prognostic scoring system for epidermal necrolysis. So the score 10 is a scale that was developed to help assess the severity and predict mortality of patients with epidermal necrolysis. It is best if we start the calculation within the first 24 hours of admission. It's the most accurate way for us to get the prognostic scoring system of our patient. If possible, within the first 24 hours, we should take note of all these 7 criteria. First, let's check the patient's age. If the patient is older than 40 years, if the laboratory indices are like this, if urea is less than 10 millimoles per liter, glucose more than 14 millimole per liter, bicarbonate less than 20 milliequivalents per liter, if the patient has tachycardia, meaning heart rate of more than 140 beats per minute, in some books, it's 100, even 120 beats. We can already count that. If the patient has presence of a malignancy, and if there's more than body surface area of 10%, more than 10% at presentation. So for these 7 criteria, if each criteria is fulfilled, we will give a score of 1 point. Okay, so let's look at so example, 1 point for this, 1 point for urea, 1 point for glucose, 1 point for bicarbonate, and the like. So let's see. So here, so it depends on what score we get, and this will be the equivalent mortality rate. So if the patient gets a score 10 of 5, unfortunately, there's a 90% mortality rate already for the patient. Okay, so for treatment, epidermal necrolysis is a life-threatening disease that requires optimal management. So early identification and withdrawal of suspect medications in drug-induced cases, which are the most oftentimes drug-induced, are essential for good patient outcomes. So that's the most important part of the management. Early identification and early withdrawal of suspect medications. Treatment consists mainly of supportive care, meaning careful wound care, hydration, nutritional support, and an appropriate hospital setting for these patients. So even in cases requiring immediate referral to specialized wards, the dermatologist will have a specific role in the management of patients with EN. So do not forget to co-manage with the dermatologist. So prompt withdrawal of offending agents is associated with an increased rate of survival. It really helps a lot to promptly withdraw the offending agents. So at the same time, it is preferable to continue every important and non-suspected medication. So you can't just say, stop all the medications of the patient. Kawawa na yung patient. It might even lead to higher mortality if you do that. So it's really important that you take a proper drug history, very detailed, make a drug timeline so that you'll know which are suspect medications and which are not. So this would be of medical benefit for the affected patient. Furthermore, it may furthermore avoid reluctance of the patient's physician to prescribe them in the future. Okay, so in case of doubt, all not life-sustaining drugs should be stopped and initiated, if initiated, and administered within the previous 8 weeks. So if you really don't know what's causing it, then okay, all non-life sustaining drugs should just be stopped. Okay, especially if these drugs have been started during the previous 8 weeks or 2 months. Okay, so only patients with a limited involvement, meaning a score 10 of 0 or 1, and a disease that is not rapidly progressing can be treated in regular wards or regular hospital rooms. Otherwise, if the score 10 is higher than 1, they should be transferred to either an ICU or a burn center. Okay, so we should provide supportive measures for these patients, maintaining hemodynamic equilibrium, prevent life-threatening complications. So the aims are actually similar for those being treated for extensive burns. So, EN is associated with a significant fluid loss from erosions, which results in hypovolemia and electrolyte imbalance. Therefore, fluid replacement must be started as soon as possible and adjusted accordingly every day. So again, peripheral venous lines are preferred over central lines when possible because the sites of insertion of central lines are often involved in detachment of epidermis and also prone to infection. Okay, so the environmental temperature for these patients should be raised to 28 degrees Celsius to 30 degrees Celsius because they usually have a problem already with thermoregulation because of their lack of epidermis. So the use of an air fluidized bed improves patient comfort if available. Okay, so early nutritional support is preferentially provided via nasogastric tube to promote healing of the esophagus to decrease the risk also of bacterial translocation from the gastrointestinal tract. And then to reduce risk of infection, aseptic and careful handling is required. And then skin, blood, and urine specimens should be cultured for bacteria and fungi at frequent intervals. So as I said, not only once. Prophylactic antibiotics are not really indicated. That's why unless there's an infection, that's why we should really watch the patient closely. Patient should receive antibiotics when clinical infection is suspected. And then prophylactic anticoagulation should be provided during hospitalization. So yeah, for prophylactic anticoagulation, this one is kind of required. So extensive and aggressive debridement of necrotic epidermis and in epidermal necrolysis is not recommended, okay? Because the superficial necrosis is not an obstacle to the patient's reepithelialization or the patient's healing. And it could even further reduce the patient's epidermis or the patient's skin if we do debridement. So eyes should be examined daily by an ophthalmologist, and usually the ophthalmologist would give preservative-free emollients or eye drops, antibiotic or antiseptic eye drops if needed, and vitamin A are often used every 2 hours in the acute phase. Okay, so the mouth should be rinsed several times a day with antiseptic or antifungal solution. And to be sure, we have to co-manage these patients with an ophthalmologist and an ENT specialist. So let's look into the specific treatment in the acute stage. So these are the medications that we could possibly give these epidermal necrolysis patients. So first would be systemic corticosteroids, the use of which is still controversial because some studies concluded that steroids were associated with an increased mortality and increased risk of sepsis when administered for 2 to 3 weeks. However, other studies found that steroids could prevent the extension of the disease when administered during the early phase of epidermal necrolysis, especially as intravenous pulse doses for a few days only. Okay? So there's a way of correctly giving systemic corticosteroids. So usually in pulses and only for a short duration. Okay, next option would be in the acute stage would be high-dose intravenous immunoglobulin or IVIG. This is based on the hypothesis that FAST-mediated cell death can be evaded by the anti-FAST activity present in commercial batches of normal human immunoglobulin. However, later findings revealed that the FAST pathway was not or only marginally involved in the mechanisms of EN. So based on the most recent studies, conclusion is that IVIG should not be used to treat patients with EN. Okay, next would be cyclosporin A. This is a powerful immunosuppressive agent associated with biological effects that are theoretically useful in the treatment. So a recent study concluded that its use was beneficial both in terms of halting disease progression and survival. So the most recent protocol is to give 3 milligrams per kilograms body weight for 10 days only, with a usual dose adjustment in cases with renal failure. Yes, for cyclosporin A, we should be very careful in patients with concomitant renal diseases. Okay, next would be plasmapheresis or hemodialysis. So the rationale is to prompt the removal of the offending medication, its metabolites, or inflammatory mediators such as cytokines. So a small series reported their efficacy and safety in treating EN. However, this lacks evidence and there are risks associated with intravascular catheters. Therefore, plasmapheresis or hemodialysis is also not recommended. So next would be anti-tumor necrosis factor agents. So anti-TNF monoclonal antibodies have been successfully used to treat a few patients. Recently, a study comparing corticosteroids and etanercept, an anti-TNF agent, reported improved clinical outcomes in patients with EN treated with etanercept. However, there was a prior randomized controlled trial of thalidomide, also an anti-TNF agent, that had to be interrupted because of the significantly increased mortality. Therefore, conclusion would be extreme caution is suggested in the use of these anti-TNF agents to treat epidermal necrolysis. Okay, so just a review, dermatologic manifestations of epidermal necrolysis so that you'll know if you're gonna suspect them in patients are confluent, purpuric, meaning kind of violaceous, and erythematous macules evolving to flaccid blisters and epidermal detachment that often start on the upper trunk and spread to the limbs associated with mucous membrane involvement. Okay, and these are the different therapeutic options that should be instituted. And here below are the medical treatment options. Okay, so for prevention, first, I really have to emphasize that we should properly evaluate drug causality. The most useful clinical criteria are duration of treatment before onset, typically 4 to 28 days or up to 8 weeks before, absence of prior intake, and use of a drug known for being associated with a high risk for epidermal necrolysis. Okay, so this is just a guide again on how to identify suspected drugs. So a list of the suspected medications and the molecules of the same biochemical structure must be given to the patient on a personal allergy card or allergy passport so that the patient would know and the future physicians of the patient would also be aware. It may be useful to provide a list of drugs of common use that cannot be suspected also so that future physicians of the patient will be confident that, oh, these are the drugs that are not suspected. These are the drugs that are suspected, and these are the drugs that are not suspected. So for sequelae are frequent and could be severe. So this is different pa from the acute phase. So 90% of patients who survived EN had a sequelae 1 year after the acute stage of the disease. So in SJS10, scarring can affect multiple systems by resulting in sequelae. Uh, a lot of areas can be affected, like the skin, the different mucosa like eyes, mouth, genitalia, lungs, and even psychiatric sequelae are possible. So just remember that in the acute phase, the epidermal detachment progresses for 5 to 7 days. Then the patients enter a plateau phase, which corresponds to progressive reepithelialization. This can take a few days to a few weeks, depending on the severity of the disease and prior general condition of the patient. So during this period, life-threatening complications such as sepsis or systemic organ failure may occur. Okay, so since late complications and sequelae may develop insidiously, it is strongly suggested that all patients surviving EN have a clinical follow-up a few weeks after discharge from the hospital and 1 year later. But better if more frequent follow-ups. So including examination by the different specialties as applicable, like ophthalmologists and other organ specialists, as indicated by the abnormal signs and symptoms that the patient had. So close follow-up is advice for these patients after discharge. Okay, so that's all for epidermal necrolysis and the cutaneous drug reactions. So now let's go to the second part of our topic, which are the benign and malignant tumors of the skin. So let's start with the benign tumors. First is seborrheic keratosis. So seborrheic keratosis is the most commonly acquired benign epithelial tumor of the skin. It can occur anywhere on the cutaneous surface, with exception of the palms and soles. So we cannot have seborrheic keratosis on the palms and soles. This is common in middle-aged and older adults and have a range of clinical appearances. So differences in clinical morphology often correspond to different microscopic variations, which I'll discuss later. Okay, so um, seborrheic keratosis begin as circumscribed tan brown patches or thin plaques. Over time, they may become more papular or verrucous with a greasy scale and stuck-on appearance, meaning it's like they have their stickers that were just stuck on the skin. Okay, so this could be rapidly growing, symptomatic, or atypical lesions. If they are so we should biopsy to rule out malignancy. Okay, if the seborrheic keratosis is rapidly growing, symptomatic, or atypical looking, then we do biopsy. And then there's also instances when there's multiple eruptive seborrheic keratosis that this may be indicative already of internal malignancy, termed as the lesser Trelat sign. And for these, gastrointestinal malignancy is the most common, followed by lymphoproliferative disease. So if you're presented with a patient with sudden, eruptive, multiple seborrheic keratosis, consider it to be, but what if it's the lesser Chalat sign? Therefore, work up for gastrointestinal and lymphoproliferative disease. Okay, so for the etiology and pathogenesis, the precise cause of seborrheic keratosis is unknown. Most are sporadic. A family history is attainable in some instances, suggesting also a genetic predisposition. Sun exposure may also contribute to their pathogenesis. And then the monoclonal nature of these neoplasms was established. So by tracking polymorphisms in human androgen receptor, researchers found that more than half of seborrheic keratosis sampled were clonal in nature. So here are the different clinical variants of seborrheic keratosis. So first would be the common seborrheic keratosis. These have the classic verrucous stuck-on appearance of papules and plaques. So here, an increased number of melanocytes and pigment may be present, resulting in a tan or brown coloration. So this is this photo on top. Next would be reticulated seborrheic keratosis. So this present as pigmented patches or thin papules. So they're much thinner compared to the common seborrheic keratosis. They could be thin papules or even just patches with pigment. So these actually may arise from solar lentigenes or sunspots. So first, after chronic sun exposure, the patient can have solar lentigenes, sunspots. Eventually, these can become slightly elevated. So they have already like converted into a reticulated seborrheic keratosis. So next would be dermatosis papulosa nigra, the next variant. This most commonly presents as multiple small dark brown to black keratotic papules on the malar region of individuals with Fitzpatrick type 4 or greater. For Filipino skin, yan, we have around more or less, we have Fitzpatrick type 4. Oh, so for patients with color, we can present with dermatosis papulosa nigra like this in the picture. And this is common on the face, neck, and upper chest. Next would be the polypoid seborrheic keratosis. This is similar to skin tags and may assume a polypoid configuration, meaning they're pedunculated. Particularly, this would occur on the neck or intertriginous areas, and they kind of look like skin tags. but maybe more pigmented, more rough. Okay, so for the treatment, for clearly benign lesions, that have destructive techniques are already effective. For example, cryotherapy or freezing, electrodesiccation or cautery, followed by curettage or scraping, and even laser ablation. Okay, so we should just warn patients that these destructive measures also have complications such as scarring, pigmentary alteration, incomplete removal, and there's always a possibility of recurrence. So multiple treatments may be required to ensure lesional eradication. So care should be taken to minimize the risk of scarring. Okay, so next, let's proceed to the next benign tumor, which is milia or milium. So for singular, it's milium. Plural is milia. So this results from pilosebaceous or eccrine sweat duct plugging. So the superficial lesions can be primary or secondary. For the secondary, this results from injury to the basement membrane of the skin. For example, the patient loves to scrub his or her skin. So eventually, some of the sweat ducts can become damaged, can be injured their base on the basement membrane, and will eventually lead to milia formation. So secondary lesions are common aside from scrubbing, can also occur in burns or those with subepidermal blistering diseases such as epidermolysis bullosa and porphyria, and even after dermatologic procedures such as dermabrasion or ablative laser resurfacing. So anything that's traumatizing to the skin can cause milia development, which is uh, pilosebaceous or eccrine sweat duct plugging. So this presents as 1 to 2 millimeters white domed papules. They are commonly located on the cheeks and eyelids of adults. Eruptive milia have also been reported, though this is a rare occurrence. And milia and plaque is a plaque-type inflammatory variant of milia that is commonly located on the ear. So this picture, this is milia and plaque at the back of the ear. No? Acquired milia can be located anywhere that the predisposing trauma or other factors have occurred. So where the trauma has occurred, that's where the acquired milia will arise. Okay, so milia are common congenital and acquired lesions in both infants and adults. Men and women are equally affected. So close differential diagnosis of milia are closed comedones. They may appear clinically similar if they are in isolation, but comedones are more likely to contain a mixture of bacteria, keratinaceous debris, and hair shaft fragments. So they're different, two different entities. So for histopathology, we would see that milia are actually minute epidermoid cysts. They are lying, if a biopsy is taken and checked, they are lined by stratified squamous epithelium and filled with keratin. Occasionally, a connection to the eccrine ducts or villous hair follicles may also be observed, and bacteria are not usually present in milia. So treatment, we extract the lesion through a small incision. So this is the first option because the cyst wall of these tumors is typically less adherent to the surrounding stroma compared to the epidermoid cyst. Because in the epidermoid cyst, usually, even if we do a small incision and try to extract it, usually we won't be successful. But in milia, there's a high chance that we'll be successful. Or another possibility of treatment would be the complete excision or destruction of the cyst lining. This is actually the definitive treatment, especially if extraction is not possible. This option will also prevent cyst recurrence because if it's just option one, extraction, there's a high chance that the cyst milia will recur. So for number two, ayan, prevent cyst recurrence already. And the same, so this is also the treatment that we do actually for epidermoid cysts, okay, which is complete excision. Okay, next condition would be syringoma. So these are benign appendage tumors typically seen in adolescent and young adult females. So as here in the picture, often present as multiple 1 to 3 millimeters, flesh-colored, sometimes yellowish papules, commonly on the face and in a periorbital distribution. But if it's already a lot, sometimes it can spread to the whole face. They can also present on the scalp, vulva, penis, chest, and axillae. So syringomas are derived from the intraepidermal eccrine ducts. So microscopically, Syringomas are well circumscribed and composed of epithelial cells arranged in cords, nests, and small ductal structures within a sclerotic stroma in the upper dermis. So the ductal structures classically have a tadpole-shaped or comma-shaped tail. Okay, and the lumina of the cells contain PAS positive material. So we see these findings if we do a histopath analysis of the syringoma. So differential diagnosis for the syringoma are milia, xanthelasma, which are a lipid deposition, and angiofibroma. So for management, as syringomas are benign neoplasms, treatment is focused on cosmesis only. So destructive methods such as laser, chemical peels, electrodesiccation, and surgical excision have been used with varying results. So again, we have to warn the patient that the possible adverse effect of doing these destructive methods is scarring. There's always a possibility of scarring. Okay, next would be sebaceous hyperplasia. So after this lecture, you'll be able to differentiate all of these already, these four. So for sebaceous hyperplasia, these are very common lesions in older persons and are confused with small BCCs. Actually, BCC can be really a differential for sebaceous hyperplasia. These lesions are BCC or basal cell carcinoma. So these lesions are 1 to 3 millimeters in diameter and have both telangiectasia and central umbilication. And so I'm not sure if you can see it in the picture, but some of them have a central umbilication here. So to distinguish sebaceous hyperplasia from nodular BCC, sebaceous hyperplasia is soft to palpation, not firm as in nodular BCC. So sebaceous hyperplasias can be treated with light electrocautery and curettage or scraping. So next, let's proceed to the common acquired nevomelanocytic nevus, or these are the moles. So synonyms are nevocellular nevus, common nevus, melanocytic nevus. So these are all common acquired melanocytic nevi. So lesions are pigmented or skin-colored macules or papules, which tend to be uniform in appearance and relatively small in size. They primarily develop during childhood or early adulthood. So increased numbers of acquired nevi impart an increased risk for melanoma development. So we have to take note of that. So these nevi develop after birth. They slowly enlarge symmetrically, stabilize, and regress after a period of time. So the number of nevi peaks in the third decade of life and then declines after. So the prevalence of acquired nevi also varies according to the ethnicity. Okay, so nevi tend to be increased in individuals with light skin tone and those who have a tendency to sunburn. So those with light skin are more prone to having nevi. So the majority of common nevi, so usually they have these features, no? They are less than 6 millimeters in diameter, have a homogeneous surface and coloration pattern, they are round to oval in shape, they have sharply demarcated borders, and most are skin-colored pink or brown. So these are the classic characteristics of common acquired melanocytic nevi. So if it varies from this, then we should do a biopsy and consider other conditions, especially malignant conditions. So very dark brown or black nevi are unusual for people with light skin tones and should be viewed with suspicion. On the other hand, darkly colored nevi are common in those with dark skin tones. Okay, so blue, gray, red, and white areas are not typical for common acquired nevi and should raise a concern for melanoma. So nevi of the nail apparatus commonly present as linear longitudinal streak of dark or light brown pigment from the nail matrix extending to the distal edge of the nail plate. So extension of pigment into the proximal nail fold in this area or beyond the distal nail groove should be considered suspicious for melanoma already. So more or less, this one on the left looks like a nevi of the nail apparatus, while this one on the right that already looks like melanoma since the pigment has extended into the proximal nail fold. So according to histologic level of nevus cell clusters, These are the classification of common acquired melanocytic nevi. So first group would be the junctional melanocytic nevi. So usually the nevi starts as junctional. So and then later it would change. So later I'll show you. So junctional melanocytic nevi, these are flat and dark. Nevus cells arise at the dermal epidermal junction on the epidermal side of the basement membrane. So it's more of, although it's in the dermal epidermal junction, it's more of in the epidermis. It's usually seen in childhood until teenage years. So eventually, these junctional nevi can progress, or I mean not progress, change into compound melanocytic nevi. So at this stage, they are already raised and dark. So nevus cells invade the papillary dermis already. So the nevus cells go down deeper. And the nevus cell clusters are now found both intraepidermally and dermally. So both. Diba, earlier in junctional nevi, they are mostly on the epidermis. So at this stage, the compound melanocytic stage, they are both in the epidermis and in the dermis. So again, this is seen in childhood and teenage years usually. Okay, then eventually, these nevi can become dermal melanocytic nevi. So at this stage, they are already light-colored and raised. They are almost always without pigment or light pigment only. These represent the last stage of evolution of melanocytic nevi because here there's already dropping off or they have gone deeper into the dermis. So dropping off into the dermis is now completed and the nevus grows or remains intradermal. So it's mostly in the dermis already, in a deeper layer. So this one is usually seen in patients in the third or fourth decade of life. Okay, so melanocytic nevi undergo the evolution from junctional to compound to dermal melanocytic nevi. The capacity of these nevus cells to form melanin is greatest when they are located in the dermal epidermal junction. So when they are still junctional nevi and lose their capacity for melanization, the further they penetrate into the dermis. That's why here, dermal melanocytic nevi, they're usually without pigment or with light pigment left. Okay, so hence the lesser intensity of pigmentation with increase in the dermal proportion of the nevus. Okay, so what are halo nevi? So these are usually asymptomatic, often multiple, and most commonly affect the trunk of teenagers. The halo phenomenon signifies self-immunologic regression of a pre-existing melanocytic nevus. So over time, the central nevus may lose its pigment and disappear, followed by gradual repigmentation of the entire area. So, but still, it's possible that there's an atypical gross appearance, particularly in adults, and you should also raise suspicion for a dysplastic or atypical nevus or a melanoma. So, if the features of the halo nevi look suspicious, and we should still suspect dysplastic nevus or melanoma. Okay, so what are the risk factors of having common acquired melanocytic nevus? So number one is environmental exposure to UV radiation. This appears to be the most critical risk factor for the development of acquired nevi, with intermittent intense sun exposure appearing to impose greatest risk for nevus development. So a randomized trial assessing sunscreen use on nevi development in school-age children demonstrated a significant reduction in the number of nevi on intermittently sun-exposed body sites compared with the control participants. Okay, so their environmental exposure to UV radiation, most critical risk factor. Okay, number two would be genetic factors that appear to play a role in the development of these nevi. The size, frequency, and distribution patterns of acquired nevi tend to be aggregate in families. So this observation is also well documented for a typical nevi in the setting of dysplastic nevi and melanoma syndromes. So yan, genetic factors. Next, for the diagnosis of melanocytic nevi, it's usually made by clinical inspection, assessing that the lesions have these features, the safe features. So when suspicious for malignancy, we should send the specimen for histopathology. Okay, special tests can also be done. So immunohistochemical profiles may be of value for difficult to diagnose lesions. So low Ki-67 activity and less loss of HMB45 in deeper dermal cells may help support a benign diagnosis. And fluorescent in situ hybridization or comparative genomic hybridization analysis may be useful in discriminating anevoes from anevoid melanoma. So there we can do special tests. Okay, so for the clinical course and prognosis, the majority of acquired nevi are harmless. New nevi may continue to appear and disappear throughout life, but most develop during childhood and early adulthood. New or growing nevi in older individuals are more worrisome, and melanoma risk appears to be related to the number and size of nevi. Patients with numerous nevi, dysplastic nevi, and a personal or family history of melanoma should be closely monitored with periodic surveillance examinations for life. So for the treatment, the vast majority of acquired common nevi require no treatment. So the indications for removal of benign appearing lesions may include either cosmetic concerns or continual irritation. Lesions with worrisome clinical features need to be excised, of course, for histopathology examination. Dermoscopy may be used to differentiate benign from potentially malignant features. So dermoscopy is dermatoscope is a device used that could greatly magnify the appearance of a lesion. So photographic surveillance can play a critical role in identifying change or lack of change in suspicious nevi. So the clinician can also take serial photos. So complete removal of nevi is best accomplished by excision, because if we leave a partially excised nevus, regardless of the initial pathology, it is fraught with potentially concerning consequences of repigmentation, regrowth, or both. And for recurrent melanocytic nevi, so this is the name given to recurrent lesions after incomplete removal of the benign nevus. Recurrent melanocytic nevi would present a markedly atypical clinical and histopathologic appearance, okay, making these lesions worrisome for possible melanoma. So if a nevi is benign and it was removed by incomplete or partial removal, it could even turn into a melanoma or show features of melanoma. Okay, so continuation of treatment, destructive methods of therapy like electrodesiccation, cryotherapy, dermabrasion, laser, and those sometimes in the market they would sell these kasoy oil. These should all be avoided. These destructive modes of therapy preclude histopathologic assessment of the treated nevi, and they may have disadvantage of not providing tissue for histopathology. And again, recurrence with worrisome clinical features may complicate future management. So for prevention and counseling, there appears to be a direct relationship between the number of acquired nevi and sun exposure and a decrease with sunscreen use. So we should advise sunscreen use. So sensible UV radiation exposure includes confining outdoor activities to early morning or late afternoon or evening. We should avoid the most intense UVR exposure occurring 2 hours on either side of noon, meaning 10 a.m. to 2 p.m. If possible, don't get exposed to the sun. And if you get exposed after or before or after these hours, use sunscreen. So cover-up clothing that blocks light transmission should be worn during intense UVR exposure. So clothing is often easier to put on than sunscreen and does not rapidly wear off with swimming or sweating. So effective sunscreens should be used as part of a comprehensive sun protection program, and vitamin D supplementation should be recommended for patients who diligently practice UVR avoidance and protection. So we just give vitamin D supplements. Okay, so next we go to the malignant lesions. So let's start with keratoacanthoma. Actually, for keratoacanthoma, it has always been controversial whether it is benign or pre-malignant or malignant. So on latest literature, they would classify it already as malignant. So in our lecture, I put it under the malignant tumors. Okay, so keratoacanthoma is commonly regarded now as a subtype of highly differentiated squamous cell carcinoma with atypical clinical and histopathologic features. This usually erupts rapidly within a few weeks, so that's a clue to keratoacanthoma. Rapidly erupts within a few weeks and it actually has the ability to spontaneously regress. Okay, so it presents as a sharply circumscribed, firm nodule with central horn-filled crater. It typically arises on the head and sun-exposed areas of the extremities. Again, sun exposure for this is a risk factor. Okay, so that's it for keratoacanthoma because now I'll be discussing in more detail squamous cell carcinoma, which keratoacanthoma is also a part of. So SCC is the second most common skin cancer after basal cell carcinoma in immunocompetent individuals. SCC development in the skin is considered a multi-step process. Most invasive SCCs develop from pre-invasive lesions or in situ tumors such as actinic keratosis, this picture on the left, and Bowen's disease, this picture on the right. So these are pre-invasive lesions or in situ tumors that could eventually be where the SCC develops. Okay, so for epidemiology, this incidence increases with age. Most affected individuals are 60 years old or older. Incidence is higher in men than in women. And cumulative lifetime exposure to UVR is thought to be the predominant etiologic risk factor for skin carcinogenesis. So cumulative lifetime exposure to UVR. Therefore, lifestyle changes, and it was observed that lifestyle changes, for example, those who would increase voluntary exposure to UVR during the past decades, have been suggested to have caused an overall increase in the total number of SCC in most countries. Okay, so sun-sensitive individuals, meaning individuals with red hair, blue eyes, fair complexion, at a higher risk for developing SCC than individuals with darker pigmentation. So albinism is associated, of course, with a high risk for SCC, even in Black individuals. So if the Black individual has albinism, he is also at high risk for SCC. So this provides further evidence for the relationship between skin carcinogenesis and sun exposure and the protective effect of eumelanin in our skin. So the eumelanin or melanin protects us also from the sun. So risk factors for SCC are ultraviolet or UV exposure, radiation, that's number one, then genetic predisposition, physical and chemical carcinogens, immunosuppression, some drugs, viral infection like HPV, chronic inflammation of the skin, for example, recurrent trauma or chronic injury of the skin like burns. And these are all risk factors for SCC development. So for the pathogenesis, mutations in the tumor suppressor gene, P53 or TP53, are the most prominent aberrations in skin cancers in SCC. These are likely to be the cause of the marked genomic instability observed in SCCs. So for the clinical presentation, variations depend on the histologic subtype and the location of the tumor. Typically, SCCs arise on sun-exposed areas, especially of the face, head, and neck region, and the forearms and dorsum of the hands. So in UV-exposed skin, SCCs usually develop on a background of actinic keratosis and Bowen's disease as precursor lesions, like I mentioned earlier. So numerous precursor lesions on UV-damaged skin constitutes a high risk for progression to SCC. So de novo formation of undamaged skin rarely occurs. So it usually rarely occurs that there's normal skin, then suddenly there's an SCC. That's rare. Usually it's already UV-damaged skin that could already have some actinic keratosis or Bowen's disease that will progress to SCC. So here in this picture, there are two nodular SCCs and several actinic keratosis, which are the precursor lesions for this patient. So all these lesions, the SCCs and the actinic keratosis, are on heavily sun-damaged skin of the patient's forehead. So the typical finding of SCC includes slowly enlarging, firm, skin-colored to erythematous plaques or nodules with marked hyperkeratosis. Ulceration, exophytic, or infiltrative growth patterns are seen. Okay, so diagnosis of SCC is established histologically. So the standard histopathology report of SCC should include the following in order to facilitate correct management. It should be written what the histologic subtype is, the grade of differentiation from G1 to G4, if it's well differentiated to poorly differentiated, and then the maximal vertical tumor diameter in millimeters, and then the extent of the dermal invasion, meaning the Clark level, and then the presence or absence of perineural, vascular, or lymphatic invasion. Okay, so high-risk features for local recurrence and development of metastatic disease would include more than 2 millimeters thickness, Clark level higher than 4, perineural invasion, lip or ear as a primary site, and poor or undifferentiated tumor. So in addition to the subtyping of cutaneous SCC, histologic grading of SCC is very important with respect to recurrences and risk of metastasis. So there's a classification system that includes histologic grading in consideration of the so-called high-risk features for staging. So tumors are graded in a scale of 1 to 4 based on increasing percentages of undifferentiated cells. So, if SCC is suspected, a complete examination of the skin should be performed, followed by assessment for nodal involvement of the regional lymph nodes, either by palpation or by ultrasound examination. So, there's a current classification and staging of cutaneous SCC. No, so it's here. So, T1 are low-risk tumors, T2 are high-risk tumors, T3 for tumors that invade the muscle, bone, or cartilage of the maxilla, mandible, or orbit, and T4 are tumors that invade the skull base or axial skeleton. So that's for the T or tumor. Okay, for the lymph node involvement of cutaneous SCC significantly increases the risk of recurrence and mortality, especially in high-risk tumors. If evaluation for nodal involvement of the regional lymph nodes by palpation and their ultrasound examination is suspicious, histologic confirmation should be sought by fine needle aspiration of the lymph node for biopsy. So, the classification, I won't expect you to know these on the right. These are just nice to know. So just an overview for the nodes. It's classified N1, 2, and 3. The other classification would have 5 categories. And then for metastasis, it's MO for no metastasis and M1 for distant metastasis. So you'll you should just have an idea of the existence of this table, but no need to know this in detail for your exam. No need. Okay, so for the management, we are also guided by the NCC guidelines for squamous cell skin cancer. This is to know the risk factors for local recurrence or metastasis in a patient. So what's important for you to know here are these. So area H is the mass area of the face, no, meaning the central face, eyelids, eyebrows, periorbital, nose, lips, cutaneous and vermilion border, chin, mandible, preauricular and postauricular skin, sulci, temple, ear, genitalia, hands, and feet. So for area H, if it's in area H, that means it's high risk. So it just means that the recommended procedure for those SCC in the area H or high risk area would be already most micrographic surgery for optimal tumor clearance and maximal tissue conservation. Okay, so surgical excision is regarded as the primary mode of therapy for localized SCC and has a cure rate of 95%. So ideal, of course, for surgical excision would be the most micrographic surgery. A topical therapy such as topical imiquimod, topical or intralesional 5-fluorouracil, cryotherapy, and photodynamic therapy are the options for topical therapy. For radiation therapy, this is a treatment option for those with superficially invasive or small SCCs in low-risk areas, for inoperable tumors, and for post-operative adjuvant treatment for patients already treated with surgical excision. So we can do adjuvant treatment of radiotherapy for patients who already had surgical excision. Okay, next would be chemotherapy. The standard options in metastatic or locally advanced or unresectable SCC include systemic platinum-based chemotherapeutic regimens, meaning 5-fluorouracil or capecitabine, and monotherapy or chemotherapy with methotrexate. Okay, so for the prognosis, local recurrence may result from failure to completely treat the primary tumor. So local recurrence rates are considerably lower with microscopically controlled surgery or Mohs surgery as compared to other local treatment modalities. Okay, so the risk of developing metastasis from SCC is generally low with a 5-year metastatic rate of 5%. So these are the key factors for SCC prevention. So education for skin cancer risk factors, effective UV protection measures, and regular self-examination of the patient. And then the sun avoidance and sun protection. And then close dermatologic surveillance, those for high-risk individuals. And effective treatment if the patient already has SCC precursor lesions such as actinic keratosis and Bowen's disease. Okay, so next let's go to basal cell carcinoma or BCC. So this is the most common cancer in humans. It accounts for approximately 75% of all non-melanoma skin cancers. BCC is more common in patients older than 60 years of age, but frequency is increasing in people younger than 50 years of age. So risk factors for BCC are ultraviolet radiation, light hair and eye color, Northern European ancestry, and again, light-skinned individuals. Okay, so the contribution of high-intensity sunlight exposure to BCC development has been well established already. So a latency period of 20 to 50 years is typical between the time of UV damage and the clinical onset of BCC. Therefore, in most cases, BCCs develop on sun-exposed skin in older adults, most commonly on the head and neck. Okay, so here, it's just important to know that all BCCs have mutations activating the hedgehog signaling pathway. BCCs are caused by exposure to ultraviolet light and are associated with PTCH1 gene mutation in most cases. So PTCH1 is the receptor for growth factor hedgehog. So you don't need to know the details of this mammalian hedgehog signaling pathway. Okay, so for clinical manifestations, BCCs are locally destructive but rarely metastatic. The presence of any non-healing lesion should raise a suspicion of skin cancer. So BCC develops on sun-exposed areas of the head and neck, but it can actually occur on anywhere in the body. So for diagnosis, it is accomplished by accurate interpretation of skin biopsy results. So the preferred biopsy methods are shave biopsy, which is often sufficient, and of course, punch biopsy, better. Okay, so for subtypes, we have the nodular BCC. This is the most common clinical subtype of BCC. It occurs most often on sun-exposed areas of the head and neck and appears as a translucent papule or nodule. There are usually telangiectasias and often a rolled border. Okay, so larger lesions with central necrosis are referred to by the historical term rodent ulcer. So the differential diagnosis of BCC includes traumatized intradermal nevus, irritated seborrheic keratosis, and melanotic melanoma. So next subtype would be pigmented BCC. Sorry for the blurred picture. So a subtype of nodular BCC that exhibits increased melanization. So it's also like nodular BCC, but it's darker in color. Appears as hyperpigmented translucent papule. The differential diagnosis includes nodular melanoma and seborrheic keratosis. Okay, next subtype would be the superficial BCC, which can look just like this. It occurs most commonly on the trunk and then on the extremities, but may also appear on the head and neck. It appears as a well-demarcated erythematous patch. Okay, it's an isolated patch of eczema that does not respond to treatment. Therefore, it should raise a suspicion for a superficial BCC. No, and we should further investigate. Differential diagnosis includes SCC, lichenoid keratosis, and nomular dermatitis. Next subtype would be morpheiform BCC. This is an aggressive growth variant of BCC. Lesions may have an ivory white appearance and may resemble a scar or a small lesion of morphea. So, sorry again for the blurred picture, but you can see this in the FITS atlas naman. Possibility of morpheiform BCC and the need for biopsy are the appearance of scar tissue in the absence of trauma or previous surgical procedure, and presence of atypical appearing scar tissue at the site of previously treated skin lesion. Yan. So in these instances, you'll need to do a biopsy. A next subtype would be basosquamous carcinoma. This is an aggressive growth of BCC. It can be confused with squamous cell carcinoma, and there's actually a controversy regarding to its precise histologic classification because it shows both basal cell carcinoma and squamous cell carcinoma differentiation. Okay, next subtype would be fibroepithelioma of pincus. This classically presents as a pink papule, usually on the lower back. This may be difficult to distinguish from an acrocordon or skin tag. Okay, so for management, BCCs are primarily treated by surgical excision. At times, we can do electrodesiccation and curettage, and ideally, best would be still most micrographic surgery, and some topical agents may also be used. So most micrographic surgery often is offers superior histologic analysis of tumor margins while permitting maximal conservation of tissue compared with the standard excisional surgery. So this provides the lowest recurrence rates among all the treatment options for BCC. So for those, if we want to assess if most micrographic surgery should really be chosen, these are for if it is in these instances, like if it's a primary facial BCC with an aggressive histopathological subtype, if it's a morpheiform BCC, if it's poorly delineated or incompletely removed, and in general, all high-risk primary BCCs, recurrent BCCs, any BCC that occurs at a site where tissue conservation is desired, such as the face, BCCs at high-risk anatomic sites, including the embryonic future planes represented by the nasofacial junction and the retroauricular sulcus. Actually, that's the H area also that I showed earlier. Okay, next would be standard excision. Since standard surgery is a standard treatment of choice for BCC. However, compared to most micrographic surgery, areas of margin involvement can be missed during routine histologic evaluation if only standard excision was done compared to most. Next would be electrodesiccation and curettage. It is one of the most frequently used treatment modalities for BCC because it's the easiest to do, but it is not recommended for primary BCCs nor for morpheiform or recurrent BCCs. So for appropriately selected lesions and locations, EDC can remain an efficacious and cost-effective treatment modality. But usually we do not choose this. No? To be sure, we choose the surgery or most micrographic surgery. Next would be cryosurgery. So just like electrodesiccation and curettage, this is another destructive modality that can be used in the treatment. Okay, next would be imiquimod 5% cream. It's a toll-like receptor agonist to boost T helper 1 or Th1 type immunity. It is FDA approved for the topical treatment of biopsy-confirmed and small, meaning less than 2 cm, primary superficial BCC in low-risk locations. So the safety and effectiveness of imiquimod for other types of BCC have not been established, with up to 25% of treated patients actually failing therapy. So adverse side effects are limited to local skin reactions. Okay, so 5-fluorouracil is another topically applied chemotherapeutic agent used in the treatment of actinic keratosis and has also been used in superficial BCCs. But there's a 5-year recurrence rate of 21% for the thin BCCs. Okay. So the use of 5-FU to treat BCC should be considered carefully and should include an evaluation of the risk of recurrence and treatment failure. Next would be photodynamic therapy. It involves activation of photosensitizing drug by visible light to produce activated oxygen species that destroy the constituent cancer cells. So the long-term cure rate for superficial BCC is around 75%. However, there were high failure rates associated with this when compared to other modalities. Okay, next, radiation therapy can also be useful in cases of primary BCC, or usually just an adjunct in the treatment of BCC for cases in which post-surgical margins were still positive for cancer. Okay, so advantages include minimal patient discomfort and avoidance of invasive procedures for patients unwilling to undergo surgery. However, long-term randomized results has suggested that radiation therapy remains inferior to surgery. So platinum-based chemotherapy is also an option. So inhibitors of the hedgehog signaling pathway, meaning vismodegib and sonidegib, have been FDA approved for the treatment of locally advanced BCCs. So a combination of cisplatin and paclitaxel and carboplatin plus paclitaxel are being used also for metastatic BCC. Okay, so those are the treatment options. But best would be surgery, particularly most micrographic surgery. So for the course and prognosis, with appropriate treatment, the prognosis for most patients with BCC is excellent. So the greatest danger of BCC, again, results from local invasion. Okay, that's the danger of BCC. Metastases are rare and correlated to the size. For example, it's already more than 7.5 cm. That's when there's a risk for metastasis, or in patients with a long delay in seeking treatment for their BCC. Okay, so next we go to the last part, which is cutaneous melanoma. And I think I have 20 minutes left. Okay, so for melanoma epidemiology, incidence has increased significantly worldwide over the last several decades. So it's mainly a tumor of people, again, with fair skin. So rising incidence worldwide in countries with white inhabitants has been noted, with highest incidence rates in Australia, followed by North America and Europe. So the median age of melanoma diagnosis is 63 years old, with 15% being younger than 45 years. So most common location is the back for men and lower extremities, followed by the trunk for women, but it can occur on anywhere on the skin surface. Okay, so these are the subtypes. First would be the superficial spreading melanoma. This is the most common subtype. It's accounting for approximately 70% of all cutaneous melanomas. It is diagnosed most commonly on intermittently sun-exposed areas, most frequently on the lower extremity of women and upper back of men. So this is a subtype of melanoma most commonly associated with a pre-existing nevi. So the history of superficial spreading melanoma is often of a lesion slowly changing over months to years. So it could just be a nevi, but it is a changing nevi, then we could suspect this. It may be mistaken for an atypical nevus or a seborrheic keratosis. So its classic clinical appearance best fits into the ABCD criteria. So later we'll go into detail with this, with irregular borders and irregular pigmentation, but it may be present subtly as a discrete focal area of darkening within a pre-existing nevus. It can present with varying shades of brown, typified for most melanocytic lesions, striking aspects of dark brown to black, blue-gray, red, and gray-white that may be found in melanoma. So it could have technicolor colors. Okay, so next subtype would be nodular melanoma. This is the second most common melanoma subtype and approximately consists of 15 to 30% of all melanomas. So the trunk is the most common site, and this is remarkable for rapid evolution, often arising over several weeks to months. So this is more often lacking an apparent radial growth phase. It is common for nodular melanoma to begin de novo, then to arise in a pre-existing nevus. So yan, comparing it to the superficial spreading melanoma, which usually arises from a pre-existing nevus, this one usually arises de novo. So it typically appears as a uniformly dark blue, black, or bluish red raised lesion, but 5% are amelanotic, just like here in the picture. Early lesions often lack asymmetry, have regular borders, and are uniform in color. So differentials to consider could be basal cell carcinoma, pyogenic granuloma, hemangioma, blue nevi, or other pigmented basal cell carcinomas. Next subtype would be lentigo maligna melanoma. So this constitutes 10 to 15% of melanomas. It is diagnosed most commonly in the 7 to 8 decades, but it is uncommon before the age of 40. So it's the most common location is on chronically sun-exposed face, especially on the cheeks and on the nose, also on the neck, scalp, and ears for men. So pathogenesis is related to cumulative sun exposure rather than intermittent exposure. So cumulative sun exposure. So clinical appearance is initially flat, slowly enlarging, brown, freckle-like macule with irregular shape and differing shades of brown and tan, usually arising in a background of photo damage. It has clinically ill-defined borders, which may be obscured by background actinic damage, consisting of lentigenes, pigmented actinic keratosis, or ephelides. Okay, so it is invasive and associated with significantly higher rates of extensive subclinical lateral growth. So next would be the acral lentiginous melanoma. This is a subtype with distinct differences in frequencies between ethnic groups. So the most common form of this is the most common form of melanoma in darker pigmented individuals such as African Americans and even in Asians. No? So it's diagnosed more often in older populations with median age of onset of 65. So the most common site for the acral lentiginous melanoma is the sole of the foot, then the palm of the hand, then the subungual locations. So clinical appearance is mainly brown to black, possibly red with variegations in color and with irregular borders. So this is not thought to be associated with sun exposure compared to other types of melanoma. So sun exposure doesn't play a role here for acral lentiginous melanoma. So let's go into subungual melanoma. So earlier I already showed like subungual melanoma. It's considered a variant of ALM, generally arising from the nail matrix, most commonly on the great toe or the thumb. It appears brown to black discoloration or growth in the nail bed. So another clue that it's already melanoma is that it's dark or irregularly pigmented, longitudinal nail streak, termed as melanonychia striata, with or without nail dystrophy, and plate elevation could sometimes be seen. So earlier, I showed you a melanoma with proximal nail fold involvement. So this is actually called the Hutchinson sign, the finding of pigmentation on the proximal nail fold, which may be noted with subungual melanoma. So this one clue to differentiate it from a benign longitudinal melanonychia. So here, it's not so apparent, but I can see some proximal nail fold involvement. Next subtype would be desmoplastic melanoma. So most commonly develops in the 6th or 7th decade of sun-exposed head and neck regions. Rapidly typically have firm, sclerotic, or indurated quality, and one half are amelanotic. Often deeply invasive at the time of diagnosis with a tendency to perineural growth. So desmoplastic melanoma reveal a high mutation burden, most likely induced by UV radiation again. Next would be mucosal melanoma. Melanoma can infrequently arise on mucosal surfaces of the head, neck, regions, genital, anorectal, or even urethral mucosa. Clinical presentation include a deeply pigmented, irregular lesion, often tumorous with signs of bleeding. Okay, so as most of these lesions present initially with a radial growth phase, manifesting as a macular pigmentation, any suspicious area in these sites should be biopsied. So in both genders, the nasal cavity, as seen here in the picture, was otherwise the most frequent location for mucosal melanomas. Okay, next subtype would be the spitzoid melanoma. It is a subtype of melanoma that clinically and histologically resembles a Spitz nevus, but it tends to be larger and have asymmetry and irregular coloration. So features that favor the diagnosis of a spitzoid melanoma over a benign Spitz nevus are the larger size, lesions with thick invasive component, lesions with numerous mitosis on histology, and lesions that have clinically concerning course, such as a very rapid growth or satellitosis. Like there are other smaller lesions around it. Okay, so these are the differential diagnoses to consider in melanoma cases. For complications are usually based on metastatic disease with organs leading to symptoms associated with the affected organ. For example, pain, convulsion, and instabilities. So there are several risk factors for melanoma, but the two most important risk factors are really sun exposure and genetics. Okay. So for the pathogenesis, this involves a mutation in the tumor suppressor gene, CDKN2A, which accounts for approximately 40% of hereditary melanoma cases and leads to loss of cell cycle control and anti-apoptosis. So you don't need to know this pathway in detail. So risk factors are history of sunburns and or heavy sun exposure, blue or green eyes, blonde or red hair, fair complexion, more than 100 atypical nevi, any atypical nevi, prior personal or family history of melanoma, and those with a genetic P16 mutation. So for diagnosis, early detection is the key to improving prognosis in melanoma, as the risk of metastasis increases with infiltration depth of the primary tumor. So change in color and increase in size of a new lesion are the two most common early characteristics noticed by patients. So for the diagnosis, first we do physical examination. So clinical diagnosis can be made in 80 to 90% of cases. So this is the important ABCDE acronym for melanoma that I mentioned earlier. It's for us to detect. It's a useful tool to identify characteristics that may potentially represent melanoma. So first is for A is for asymmetry. So B is for border, C is for color, D is for diameter, and E is for evolution. So of course, if it's asymmetric, more for melanoma. If the border is irregular versus regular, or ill-defined versus well-defined, of course, it's more for melanoma. For color, if it just has one color, then it's less likely melanoma clue. But if it has varying shades, it's a clue again to melanoma. If the diameter is greater than 5 millimeters, we consider a melanoma. And if there's evolution or changes in the lesion over time. So if we suspect melanoma, again, do a biopsy. So again, on physical examination, aside from A, B, C, D, E, we can look for the ugly duckling sign. So this is another diagnostic aid. It's a pigmented lesion that is different from other pigmented lesions on a particular individual. Therefore, we should approach it with high index of suspicion. So for example, the patient has a lot of nevi, but there's this one nevus that looks different from all the others, and that's called the ugly duckling sign, and we should do a biopsy. So dermoscopy or epiluminescence microscopy is a non-invasive technique in which a handheld device is used to examine a lesion. So in inexperienced hands, it may improve both the sensitivity and specificity for a clinical diagnosis of melanoma. So morphologic features that are otherwise not visible to the naked eye could be observed using this technique. Okay, so with dermoscopy, it can help us decide if we should or if there's no need to do a biopsy. So histology, of course, for clinically suspicious lesions of melanoma, we should do an excisional biopsy. In some cases, an incisional biopsy may be performed in the most elevated or darkest area of the lesion. So there's no evidence that biopsy or incision of a primary melanoma leads to seeding of tissue and adversely affects survival. Because there are some patients who believe that if their melanoma is excised or incised, then it would allow the melanoma to spread, but there's no evidence for this. Okay, so in addition to diagnosis, histology gives further clinically important information on the infiltration, meaning the breast lobe thickness, and the ulceration status. So further diagnostic investigations are stage dependent as the risk to metastasize increases with tumor stage. So immunohistochemistry may be useful also for melanoma using these special stains. KS100, HMB45, Melan A or MART1, and MITF. So for the course and prognosis, melanoma follows a highly variable course and represents a heterogeneous disorder. This is surgically curable if diagnosed and treated in early phase. It's potentially lethal with increased risk when diagnosed at a later stage. With proper treatment, the median overall survival of 2 years in stage 4 melanoma and the chance for long-term control can be achieved. So melanoma can progress to different stages of the disease. Primary for stage 1 and 2, regional metastasis for stage 3, and distant metastasis for stage 4. So in general, prognosis and survival rates worsen with increasing stage. So this is an example of stage 4 disease with extensive cutaneous metastasis. Okay, so it's just also again nice to know that there's also a TNM classification for melanoma. So these are the tumor classifications, then the lymph node classifications, and then the metastasis classifications. Then using these, we can use those information to stage the patient, no? Whether it's stage 1, stage 2, stage 3, stage 4. So management, So wide local excision is the standard of therapy for primary cutaneous melanoma. The purpose of wider excision is to prevent local recurrence due to subclinical persistent disease. So current recommendations on the clinical margins depend on the breast low thickness. For melanoma in situ, we do a 0.5 to 1 centimeter margin. Melanoma less than 1 millimeter breast low depth, a 1 cm margin. Melanoma 1 to 2 millimeters thick, 1 to 2 cm margin. And melanoma more than 2 millimeters thick, a 2 centimeter margin. Okay, next, we can do adjuvant therapy. For example, with interferon alpha and adjuvant therapy, approval for stage 3 disease are these drugs, ipilimumab and nivolumab. Okay, for adjuvant therapy. Okay, then for chemotherapy, the alkylating agent, the carbizin, is the only FDA-approved chemotherapy for metastatic melanoma. Okay, so immunotherapy, this includes two groups, the immune checkpoint blockade, anti-CLA4 and anti-PD-1 antibodies, and the targeted therapies like BRAF or MEK inhibitors. So for the BRAF inhibitors, under this would be sorafenib, vemurafenib, and dabrafenib. And for the MEK inhibitors are trametinib and cobimetinib. Okay, so for prevention and screening, primary prevention strategies should focus on safe sun exposure, including limited UV exposure and sunburn prevention, especially in childhood and adolescence when risk is the greatest. Okay, so early detection by regular self-examinations, skin awareness, and knowledge of the early signs and symptoms of melanoma should be emphasized to the patient. And secondary prevention strategies should be early diagnosis given to these patients, which could greatly reduce melanoma-related morbidity and mortality. Okay, so for follow-up, patients with melanoma are at risk for local, regional, and distant recurrence, with the level of risk dependent on the stage at initial diagnosis. So regular follow-up is indicated for all patients with melanoma, at least annual follow-up visits for life, with a follow-up interval generally ranging from 3 to 6 months for 1 to 3 years after diagnosis, and then annually thereafter. So patients with other risk factors, such as positive family history, numerous nevi, difficulty with self-examination, would require more frequent follow-up. Okay, so that was my last slide, and my references are these. Okay, so thank you. I hope you were able to absorb most of my lecture. Good luck on your exam. So we have 5 minutes left. Does anyone have any questions, like regarding the exam or anything that I discussed? Oh, okay, so we still have a few minutes left. You might have some questions. Oh, there, I see a question. Wait. Hi, Doc. Are the tables shown in your lecture also in the said references? Yes, they are. Most of my tables are from the main Fitzpatrick book. But you don't need to open that if you were able to get it from my lecture already. But if you want to look for them in the book, yes, it's in the big Fitzpatrick book. Okay. And then for the exam, don't forget to study pictures. So I suggest you look at the baby Fitz or the small Fitzpatrick book to search for pictures on all these conditions. Because in the exam, I'll be including some pictures. Okay. And in the exam, I won't ask anything that I did not discuss. You might still have some more questions. Okay, I think there are no more questions. No more in the chat box. If you have, you can turn on your microphone. Okay, so I guess there are no more questions. Thank you to the Medicine 2 students. Thank you to everyone for attending and listening to my lecture. Study well for your exam. Good luck and God bless. Thank you. Bye-bye. Enjoy the rest of the day. Dr. Thank you. Welcome. Dr. Joko, are you still there? Thank you very